This program is brought to you by Emory University.
Today's speaker, Dr. Viola Vaccarino, who's Wilton Looney Professor of Cardiovascular Research in the Department of Epidemiology in the Rollins School of Public Health. She also has a joint appointment in the School of Medicine and Division of Cardiology. She received her MD from University of Milan and did her PhD at Yale before she came to Emory. And here she is a professor and led the Department of Epidemiology for a number of years, and is also a PI of many R01s, but also of the metric program. That is one of the training programs a lot of our trainees are part of. She performs multidisciplinary research in a number of things, both epidemiological as well as clinical trials and translational research. As you know, particular interest in women and cardiovascular disease and stress and cardiovascular disease. So it's a privilege for me to ask Dr. Vaccarino to give our inaugural lecture for this year.
So today I'm going to talk about stress and heart disease, but the main focus is going to be to give you kind of a summary or outline of a field of research that we've been working on for many, many years now, probably close to 20 years, within a group, a very multidisciplinary group here, Emory, that includes us in epidemiology, but also people in cardiology, Kaviomi in particular, others in radiology, psychiatry, Doug Bremer there, Amit Shah, who is in between epidemiology and cardiology, and many others, and more recently also the laboratory from Gary Clifford in the Department of Biomedical Informatics. So it's a lot of people have contributed this. So it's really an honor, so to speak, to share some of this data, although many of you, and I apologize for that, have already heard several parts of this talk, I'm pretty sure, not only from me, but also from Arshad, from others that have presented several pieces of this data. Okay. See how to advance this. Okay, maybe I just press the button. Okay. So we know that psychological stress has been linked to cardiovascular risk, and this is through many different lines of research, following multiple definitions and assessment tools. And there are also many different mechanisms that are involved in this connection, and only some of them actually are known at this point. For example, stress can trigger acute coronary syndromes and sudden cardiac death. So it can act as a trigger, but can also potentially worsen cardiovascular risk through cardiometabolic health. For example, it's linked with obesity and hypertension. If repeated over time, stress can potentially lead to cumulative effects and long-term cardiovascular risk, although this pathway still has not very well studied, but it's assumed that this can happen. Interestingly, high-risk populations are more vulnerable to the effects of stress on cardiovascular risk. So if you look here, for example, this is kind of a snapshot of different studies that have looked at stress as a risk factor or a prognostic factor for cardiovascular disease. And again, using a lot of different study designs, populations, tools, et cetera. Still, you can see there is a substantial consistent association of a link, of an association of different measures of stress and cardiovascular risk. But the association is stronger among high-risk populations, such as those with subclinical or clinical cardiovascular disease. Why this is still not clear. So this is a population actually we have been focusing on in our studies. Also, we should remember that the major mental disorders such as depression or PTSD or anxiety often are a consequence of stress, and they are also linked to cardiovascular disease. So some of the effects of stress can occur through mental health issues. And for example, major depression or anxiety disorders in the overall population are pretty common. The lifetime prevalence is about between 20 to 30%, and they increase the risk from 40% to 100%. But among patients with cardiovascular disease, again, the association is stronger. First of all, the prevalence is higher. Here you can see that this is the point prevalent, means it's not any time in lifetime, but it's at this specific point in time. The prevalence is between, again, 20 to 30%, so substantially higher and than in the general population. And the risk is, the association with cardiovascular risk is higher. It's between 60 to over 200%. What are the overall mechanisms? This is a slide that often I show. It's kind of depicting the one of the most common models for stress and cardiovascular disease. Stress is appraised in specific areas of the brain that are part of the corticolimbic cortex, corticolimbic system that includes areas such as the medial prefrontal cortex, the hippocampus, and the amygdala. These are all areas that are involved in emotional processing and in the regulation of the autonomic nervous system. In particular, they regulate the neuroendocrine system and the sympathetic and parasympathetic centers that in turn regulate the peripheral stress response, including changes in blood pressure, heart rate with stress, or changes in vascular function, changes in inflammation, immune function as a consequence of stress. And through these changes, through a number of molecular pathways, stress then can, in the end, affect cardiovascular risk, again, through a number of hypothesized mechanisms, from disrupting the plaque, through diminishing coronary blood flow and perfusion, through vascular inflammation, through atherothrombosis or arrhythmias. So as you can see, there are many potential pathways. And also we should remember that major depression and PTSD and major psychiatric disorders that are linked to stress are also affect this circuit in the corticolimbic system and the regulation of peripheral stress response. So they are associated with dysregulation of these systems. Again, another suggestion that mental health and stress are all linked together, potentially in affecting cardiovascular risk. But not everybody is equally susceptible to this. So not everybody is at the same level of risk. There is a lot of individual variability in the way people respond to stress. And there are also other potential moderating factors, such as even genetic factors or different coping strategies, behaviors, different things that differentiate people. And indeed, there are groups that are have been identified to be more vulnerable to the effects of stress on cardiovascular risk. A group that we have been interested in is women. As you'll see, we're going to talk more about that. And as a group, our team has been really interested in this particular area, the peripheral stress response physiology, with the idea that it's not just the exposure that may put people in a certain pathway or risk, but it's how people respond that could increase the risk. And this is an area that prior to us, I guess, it was not as much investigated, especially in connection to cardiovascular risk. And that's what we have done in a number of studies. And how do we do this? How have we done this? Using a mental stress protocol in the lab. And we have here a lot also our staff that has been so much involved in helping us with this very complex protocol. So we use a speech task where patients are asked to first prepare a speech and then to deliver it in front of a small audience of people that the patient has not met before, people wearing white coats who are not smiling, kind of more with an intimidating outlook, and who tend to give also negative feedback to the patient. So they are given 2 minutes to prepare a speech and then 3 minutes to deliver it in front of an audience, this audience that I just described. And throughout the mental stress protocol, of course, we monitor blood pressure, heart rate, ECG. Also, we use a video camera on the patient to increase the stressful component. And also at peak stress, about in the middle of the speech, we injected System-E because part of the protocol was to do myocardial perfusion imaging. So that's the radioisotope for perfusion imaging. With this protocol, we have studied about 900 participants with coronary heart disease, 600 in the MIP study, mostly chronic ischemic heart disease or coronary artery disease, and 300 in the MIMS2. These are all recent post-MI patients. And before, during, and after stress, they were all assessed in terms of hemodynamics, vascular, molecular factors. We also did myocardial perfusion imaging to measure ischemia, myocardial ischemia, and a subgroup of them underwent brain imaging with positron emission tomography. Okay, so initially, of course, we observed the number of changes, systemic changes with mental stress, which were all expected, nothing particularly new here. There was an increase in catecholamine during mental stress. There was an increase in blood pressure, heart rate. There was an increase in microvascular vasoconstriction, which we measure with this particular device. Is called peripheral arterial tonometry, or endopath. And then a little bit after the termination of the stress, between 30 and 60 minutes, we did a measurement of arterial stiffness using the pulse wave velocity protocol and endothelial function with flow-mediated vasodilation with ultrasound. So there was an increase in FMD, an increase in PNW, arterial stiffness, and a decrease in FMD. And there was an increase in inflammatory markers, particularly IL-6, which increased 34%, but also other ones like MCP1 and MMP9. So all this confirmed essentially what we already knew in the literature. But our question was really, are these stress-related changes associated with cardiovascular outcomes? That was the component that was not very known up to this moment. So we then focused again on the physiological stress response, and then we looked at all these different systems, hemodynamics, heart rate and blood pressure, myocardial ischemia, endothelial function, vasoconstriction, and inflammation. And I'm going to give you some examples of our results. Indeed, we did find robust associations in terms of the way people respond and cardiovascular risk along the line about 3 to 5 years later. For example, we found that the hemodynamic response with mental stress is associated with adverse outcomes. That was true both in the MIPS and the MIMS2 study. We looked at rate pressure product, which is the product of systolic blood pressure and heart rate. But interestingly, it was a blunted response. It was related to risk, not an exaggerated response in this high-risk population. Also, transient endothelial function was related to adverse outcomes, the way people respond to with this particular stress. stress caused a decline in FMD in about 60% of the patients. And that, again, was expected. But those who declined in FMD with stress had worse outcomes. So decline was associated with about 80% increased risk of subsequent cardiovascular events, which was independent of and stronger than the baseline endothelial function, which we know endothelial function is associated with cardiovascular risk. But here we demonstrated that not only we adjusted for the baseline endothelial function, but actually the change with stress was a more powerful predictor of adverse outcomes than the resting state. And also, we looked at peripheral vasoconstriction with mental stress, and that was also associated with adverse outcomes. We used the EndoPad device that I talked about before, and which gives you this PAT ratio, which is the ratio of pulse wave amplitude during mental stress over pulse wave amplitude during the resting period, which is a measure of sympathetic activation, acute sympathetic activation and systemic vascular resistance. Again, those who vasoconstricted more had worse outcomes. Again, about 80% increased risk when we divided up the response in according to the median.
That's too much in one cheese. You can use the little, or you can turn on the oven, one or the two, whatever you like.
All three, all your stuff? All
Yeah, one, we're gonna do.
I couldn't understand what. Oh, okay. So I just ignored. I thought it was a question. Okay. I couldn't understand. Okay. All right. So and then also we looked at immune function, and here I'm showing results for the study we did with bone, looking at bone marrow-derived circulating progenitor cells, CD34 mononuclear cells that participate in inflammatory response and vascular repair. And again, we found that a larger increase in these cells, circulating cells with stress, was associated again with adverse cardiovascular events. So this kind of gives you in general an idea of how stress response physiology indeed is affecting cardiovascular risk in this patient population. One major factor that we were interested in, actually, the two studies were designed specifically to look into mental stress-induced myocardial ischemia, which is, it's analogous to a regular, ischemia diagnosed with a traditional stress test like an exercise treadmill stress testing. But in this case, instead, it's provoked by an acute mental stressor, like the speech task I was talking about, rather than an exercise stress test. It occurs if you use perfusion imaging in about 15% of patients with heart disease. It is usually silent. It is in some way related or correlated to ischemia with a conventional stress test, but it's actually an independent phenomenon. First of all, it can occur even in settings of normal exercise stress test. And it's less tightly linked to severity of coronary artery disease. In fact, you can see as a proof of concept, here you have the data of a person, one of our patients, who developed a perfusion defect with mental stress, but not with exercise stress, kind of proof of concept. The two phenomena are not the same thing. And we did find that the myocardial ischemia with the mental stress is associated with adverse cardiovascular outcomes. That was true in both MIPS and MIMS, and even actually a little more pronounced in the MIMS-2 study. But in both studies was a very strong relationship. And when we combine the two cohorts together, the pooled hazard ratio was 2.5, so over twofold increased risk of adverse events for those who developed ischemia with mental stress, even after taking into account conventional stress ischemia. Again, so the two phenomena are independent, and more, in fact, when we looked at different phenotypes of ischemia separately, so we found that those who developed only mental stress-induced ischemia with no ischemia with conventional stress still had a twofold increased risk. Those who only developed ischemia with conventional stress tests and not mental stress-induced ischemia only had an excess of 40% increased risk, which was not even statistically significant. And those who developed both types of ischemia had almost a fourfold increased risk. So there was a clear additive effect of having both types of ischemia. Okay, now we'll shift gears a little bit and talk about ischemic heart disease in women. And why is that relevant here? It's because we have been developing this idea that stress actually plays a role in pathophysiology and perhaps also in outcomes for women with heart disease. So women with ischemic heart disease have less coronary plaque burden. This is very well established. And they tend to have a larger involvement of the microcirculation. The disease occurs later on in life, but once it occurs, it does not have a better outcome, despite the fact that women have less atherosclerotic burden. Actually, if anything, it's worse. Women tend to have a higher case fatality for MI, especially for younger middle-life women, so those who develop the disease prematurely. They have higher rates of readmission after an acute MI, and all these differences are not explained by age or comorbidity. So we have been developing this idea that perhaps psychosocial stress has something to do with this. First of all, in women, psychosocial factors are prevalent, particularly in that midlife time. And could be implicated in pathophysiology because we know that stress, in part through sympathetic activation, has this effect on inflammation, has this effect on vascular function, which we think are major factors that may affect the risk of ischemic heart disease among women. So these pathways could help us explain sex differences, perhaps through stress response physiology. And we started out by observing that myocardial ischemia is more common among women than among men, particularly in the younger middle-aged women. Here are data from the MIP study. You see the percent of ischemic left ventricle with mental stress. And you can see that there is this disproportionate occurrence of ischemic myocardium in the younger women. And there is no difference actually between women and men in the older ages. And in the MIP study, where all patients, all participants who were 60 and below of age, the occurrence of ischemic with mental stress was about twofold higher in women compared with men. And why is that? To understand potentially why we are observing these sex differences, so we can think about the etiology of mental stress-induced ischemia. Essentially, just to provide you a very schematic view of this, mental stress through sympathetic activation and release of catecholamines increases cardiac output, right? So increases heart rate and blood pressure, and that can increase myocardial oxygen demand, which in susceptible individuals could cause a perfusion demand-supply mismatch and therefore lead to myocardial ischemia. But at the same time, catecholamines through the alpha-1 receptor can increase also systemic vascular resistance through an increase in peripheral as well as coronary microvascular tone. And this can decrease coronary blood flow and can increase cardiac afterload due to the peripheral vasoconstriction, which also can lead to a perfusion demand-supply mismatch and potentially lead to ischemia. So it turns out that men are more likely to be affected by the pathway involving cardiac output, while women may be more likely to be affected by sympathetic, the systemic vascular resistant pathway. We looked at this in the MIP study, and indeed we found that in women and not in men, mental stress ischemia is associated with an increase in peripheral vascular constriction with mental stress, which was measured through with the PAT ratio, so lower pulse wave amplitude. And in parallel, in men, but not in women, mental stress ischemia was associated with an increase in hemodynamic response with the mental stress, which was here expressed as a rate pressure product. So it's possible that in women, mental stress ischemia could be mostly a macrovascular phenomenon. There could be an increased vasomotion, which we know that is tends to be more common among women, which then could lead to stress-induced vasomotion, which in turn could be a substrate for mental stress ischemia. And our data are consistent also with another line of research that Dr. Pooja Mehta here in cardiology has done. She actually has been very interested in this particular phenotype, which is INOCA, so women with ischemia with no obstructive coronary artery disease. And so she found that, first of all, we know that many patients with INOCA have coronary vascular dysfunction. And she found that women with INOCA and coronary vascular dysfunction have an increased peripheral vasoconstriction when they are under mental stress compared to normal controls. You can see here in red, particularly with mental arithmetics. She did anger recall, mental arithmetics. And also the cold pressor test is actually a stress, a physical stressor. It's not a mental stress stressor. And so INOCA women tended to have more vasoconstriction, but not with the cold pressure test. And also she found that these INOCA women have an abnormal autonomic reactivity to mental stress. So they have a lower, in this case, high frequency RA variability, but low frequency was also lower compared to, again, normal controls, as well as with a group of that did not have, with chest pain, but not cardiac chest pain. So the women with INOCA and vascular dysfunction had a lower autonomic function than these other groups. And that was true both for the anger recall and the mental arithmetics, suggesting that, again, autonomic function can have a major role in as an underlying mechanism through which women may have these vascular responses to stress. And in addition to that, we found that the microvascular responses to stress are related to adverse outcomes among women. We looked at using hyperemia testing before and 30 minutes after mental stress. We looked at this particular index, that's reactive hyperemia index, which is derived again by the same device, the PAT, the peripheral arterial tonometer. But in this case, it's more of a measure of microvascular endothelial function rather than vasoconstrictive response to acute stress. And contrasted that to flow-mediated vasodilation that was measured in the usual fashion using ultrasound, which is a measure of macrovascular endothelial function, since it's done at the level of the brachial artery. We found that a decline in RHI, which is the microvascular at the tip of the finger measurement of endothelial function, was related to adverse events in women only and not in men. Here you see the excess risk for cardiovascular events per standard deviation increase in RHI, and there was a 50% increase among women. There was no association among men. But FMD, actually, the decline in FMD was related to adverse outcomes in both women and men. There was no significant interaction. So it seems like vascular function is, in particular, microvascular function may be an important predictor, particularly among women. One of the reasons why women may have more of this response could also be due to inflammation. We know women in general have more inflammation, but particularly we've found after stress, in particular, the younger women, again. You can see here that women, particularly younger women, have higher, in this case, we are talking about IL-6, higher IL-6 levels than men of the same age at rest, but especially after stress, they have this kind of jump into the levels after stress. So the stress response, inflammatory stress response is higher among women, particularly in the younger age groups. And this change was related to adverse events as well among women. Looking at IL-6, and again, results expressed as standard deviation, and for each increase, okay, this is wrong because it's actually, it's not RHI here, it's inflammation, but for each increase in inflammatory response to stress with IL-6, there was almost 60% increased risk of adverse events among women, no association among men. There was a similar relationship also for MCP1, although not as strong as IL-6. So stress response pathways that are related to microvascular function and inflammation are especially important for cardiovascular risk among women. So women seem to be susceptible to these pathways. So stress response physiology, I hope I convinced you, that plays a central role in adverse cardiovascular outcomes among patients with heart disease, and some groups, particularly women, are more vulnerable, particularly for certain pathways. But we also know that stress response begins in the brain. That's what we started up with in the beginning of the presentation. Could we establish a direct link between brain neurobiology and adverse outcomes? So this could be a very interesting sort of proof of concept that stress actually plays a causal role in increasing cardiovascular disease risk. So we focus on this area, the medial prefrontal cortex, that has explained is part of this cortical limbic system that is involved in regulation of emotions and cognition. And it has inputs to the amygdala, hippocampus, autonomic system, all areas that are involved in the fear and stress response regulation and memory. And it's activated by social stressors, like the speech task that we are using. So using PET imaging of the brain in a number of different studies, we have found, and others, but our group, these are all our reports with Doug Brent over there being the lead author of many of these, or the senior author of many of these. We found that activation of these brain areas with stress was associated with stress-induced peripheral vasoconstriction, stress-induced myocardial ischemia, angina symptoms, and even cognitive decline. And we found that activation of the medial prefrontal cortex is also associated with adverse cardiovascular risk directly. So when we looked at whether people who had higher activation versus those who had low activation, those with high activation either expressed as a continuous fashion for each standard deviation increase in activation, there was 20% increased risk, or as a dichotomous variable at the median, those who activated more had more adverse outcomes. We also found that vagal activity that was measured with high frequency heart rate variability during the stressor explained about 1/3 of this relationship. So again, suggesting that autonomic function, in particular the vagus, may have a large part to do with these effects. Okay, so stress response physiology plays a key role in cardiovascular outcomes, but all the data that I showed you so far have been based on a laboratory protocol. So it's potentially an artificial environment. And what is the translation to the real world? We assume that what we are measuring in the lab is an approximation of how people respond in real life. But we should actually go and measure how people respond in real life. It's much more difficult, of course, but ultimately that's what we want to know. And also there are issues in terms of implementation of these mental stress protocols for clinical purposes, for screening or, for assessing prognosis in patients, because it's complicated to be actually implemented in a clinical setting. It's cumbersome, it takes a long time, it's expensive. So it's really not translatable to the clinic. So we have now begun working in the area of transitioning from lab to measurements in daily life. There are many advantages. We capture people in their natural environment, so it's more natural environment. The assessments are prospective, so potentially we avoid recall bias, which is always an issue when we measure stress. And we get repeated measures rather than just one point in time, so more precision. And potentially it could be easier to be translated to clinical care using ambulatory devices, and could have a higher potential for personalized medicine, because we are measuring so many, we are obtaining so much data, so many data points for each person. So we have done this in a study of about 300 patients, the MIMS-3 study, who were hospitalized for MI in the previous 8 months, like MIMS-2. The mean age about the same, 50, approximately 51, and 43% were women. All the participants underwent mental stress protocol, baseline, and then after the lab visit, they underwent monitoring at home for 7 days. And we monitored them with 3 types of devices. One, an app on their phone for EMA, stands for Ecological Momentary Assessment. It's an assessment of daily experiences, stress, mood, and what happens in their lives, which was programmed in this particular app. It's called the Life Data app. Programmed in a way that the participants got 3 random prompts per day at random times, where they were prompted to answer specific questions. At the same time, they were wearing the Bitium Pharos device for ECG monitoring, and also an ActiWatch for actigraphy to track activity and sleep. This is just to give you an example of how we assessed the EMA the protocol for mood and stress in regular life with live data. Randomly, they were asked during the day to report on a scale from 0, none of the time, to 100, all of the time, how much of the last hour did you feel angry? And they would answer that way with this sliding measurement here. At the same time, similar questions were asked about sadness, being anxious, happy, distressed, calm, and lonely. So we went after negative mood, but also positive mood. And we also assessed stress with questions like, within the last hour, did anything happen to you that most people would consider stressful? And if they said yes, then we would ask additional questions to understand the nature of the stressor and the impact that that event had in their life. So you can imagine we obtain many, many data points, 3 times per day, per 7 days per person. And at the same time, they were wearing the Holter monitor, the Bitium Pharos, which provided continuous ECG data during that week, which was segmented in 5 minutes, 5-minute windows for analysis. We did the analysis overall and also excluding periods of activity, so just focusing on stationary periods. But then the results were almost identical, so we focused on overall data. Sleep periods, though, were excluded, and the mean wear time was almost 7 days, so it was actually pretty good response rate. We obtained a lot of metrics from this particular ambulatory monitoring protocol in collaboration with Gary Clifford's lab. But at least for now, we have been focusing on deceleration capacity of heart rate, which is a marker of parasympathetic activity, which is pretty well established as a prognostic marker, both for post-MI patients as well as in the general population. And it's associated with cardiovascular disease risk and total mortality. It has the advantage that can be measured reliably regardless of motion and respiration, which is an advantage for ambulatory studies like this. Chronic vagal dysregulation can be defined as the proportion of the day with low deceleration capacity, defined as less or equal to 2.5 millimeter or milliseconds, sorry. So let's look at what we found in terms of psychological experiences in real life. We found that in general, women reported more adverse EMA measured experiences, including negative mood and stress across the week. They had more negative mood, they had more negative mood variability, and they reported a higher percentage of moments with stress. Interestingly, there was no difference in positive mood, so it was specific for the negative mood component. And in terms of daily autonomic physiology, we found that women had lower daily means of ECG metrics across the week. Pretty much any measure we looked at was lower among women. DC, as well as several measures of RA variability, were all lower among women, even after adjusting for a number of potential confounding factors. Then we looked at the question, is stress response physiology in the lab related to autonomic flexibility in real life? So we found that there is an association, it's a direct association between systolic blood pressure changes with mental stress, as well as heart rate changes with mental stress, and deceleration capacity averaged across the week. It's a direct association, meaning that it's, again, a blunted hemodynamic response to stress that is the risky part, that is associated with autonomic inflexibility, a lower DC. And the effects were similar in women and men, and results did not change substantially after adjusting for other factors. And then we looked at the relationship between the deceleration capacity and negative mood in real life, and we found a relationship in women only. As you can see, in women, the negative mood score, the daily average across the entire week, was inversely associated to DC, to deceleration capacity across the same week, but there was no association among men. And also, when we looked at the data in terms of low DC with a duration of less or equal to 2.5 milliseconds, the more negative mood, the higher duration of low DC, but in women only, again. And the results were really similar, looking at other autonomic measures, heart rate variability metrics, only in women and not in men. And even when we did a moment-to-moment analysis, results remain fairly similar. So here we looked at within-person associations of moment of negative mood with deceleration capacity in the hour prior to the prompt. So looking at the exact time point. And again, we found a relationship among women and not among men, which remained even after adjusting for other factors. What about perceived stress? We found that the moments of stress and moments of negative mood were related. This is not surprising. And that was true both in women and men. When they expressed stressful moment, they also had a lower mood. But in terms of relationship with autonomic function, the association was similar in women and men. There was an association, moments of stress were related to lower deceleration capacity, but it was an overall effect. There was no difference between women and men. So it looks like that women may be more vulnerable to the negative mood effects on autonomic function, while stress, like discrete events that are perceived as stressful, are related to autonomic function in a similar fashion in women and men. Okay, so in conclusion, physiological responses to stress are clearly key pathways of cardiovascular risk among patients, individuals with coronary disease. Hemodynamic, vascular, immune, ischemic changes with stress all predict risk beyond the steady state. Women appear vulnerable, particularly to vascular immune mechanisms of stress. And regulatory pathways begin in the brain and involve the autonomic nervous system. And then moving from the lab to daily life, again, we find that negative psychological experience in real life are related to ambulatory autonomic physiology. And then again, women are vulnerable to the effects of negative mood. There are many more questions, of course, that we need to address in the future. First of all, we need outcomes. We need to link these observations with outcome measures. We need to know if these ambulatory autonomic stress measures actually are clinically meaningful. They are related to adverse events. We need to contrast results in cardiac patients with populations without cardiovascular disease to understand if these relationships and also these sex differences are unique to high-risk people like those with cardiovascular disease, or they just reflect general patterns in the general population. And we need to translate these findings to the clinic and for prognostic purposes, for future interventions. We need to create new tools, perhaps using some of these ambulatory measures to be able to screen potentially people, to predict their risk in the future, and to address their value in interventions and their response to interventions as well. And that's all what I have. Thank you for your attention.
The preceding program is copyrighted by Emory University.